Well, welcome to this symposium on behalf of the ethics committees from both APSA and the Canadian Association of Pediatric Surgeons on this discussion symposium on the aging surgeon that initially began with discussion from the ethics committee raising the question, at what age should a surgeon retire? And for some unknown reason, I was chosen to lead the discussion. I have no idea why. But that concept morphed into a broader, more diverse, and I think more inclusive subject that you're going to hear today, into an issue of surgical competence as a continuum, a process that ranges from early to mid to late career stages with unique challenges and lessons that makes our surgical career more of a journey than really a destination towards retirement, and puts a new emphasis on it in terms of lifelong learning. The relevant questions we're going to seek to at least address, and hopefully you folks will have questions for us regarding this, is what really determines surgical competence? And who really is the aging surgeon? And to do that, we've decided to separate this into an early career stage, which is going to be represented by Badr Shakshir, here to my right, who's a pediatric surgeon early in his career at Washington University in St. Louis, who will talk about the development of skills, surgical skills, following training in areas that one may have had limited or no exposure to. Things that come to mind like perhaps ECMO or PDA ligation or complex airway cases or other complex surgical procedures that may not find their way into your training institution during pediatric surgical fellowship. The mid-career stage will be addressed by Ken Gao, who joins us from Seattle Children's, as a mid-career time to expand those operative skills with developing expertise and reputation in teaching and research. But perhaps in this process, one may run the risk of becoming a so-called niche surgeon in areas as diverse as bariatric surgery, colorectal, pediatric surgical oncology, or many other fields. I will handle the late career surgeon. My name is Charles Bagwell. I've been at the Medical College of Virginia, then VCU, and now our recently opened Children's Hospital of Richmond for 30 years now, and would like to promote the idea in late career of pediatric surgery as a specialty for the practice of pediatric surgery, not the individual, where one begins to look at an expanded career more as a mentor, a collaborator, a teacher with outside other interests that may be quite varied and not what one initially would think of with a pediatric surgeon. Think of administrative duties, fundraising duties, charitable organizations, or other interests. There are important themes that we will address, and one of those is everyone's path is unique and, frankly, unpredictable, subject to change, oftentimes sudden change, based on such things as institutional politics, personal health, family crises, and all of these involve stages, often imperceptible over time, but with certain themes that emerge in this process of what we've described as lifelong learning, from the beginning to the middle and towards the close. So, to begin with the beginning, Badr.
can see, I guess, on our title slide that as you gain more experience, you get more letters after your name. So I'm a little bit behind my colleagues here. My name is Badar Shakshir. Thank you for the opportunity to speak with you all today about the early career surgeon perspective, roughly described as years 0 to 7 of practice. And that's where I am, kind of right in the middle of that. And it's certainly a time of great transition from fellowship to one's first job, and usually the first opportunity at independent practice. So I separated out these first thoughts as personal and professional goal setting. Professional goals, it's time to establish one's practice, to look at creating a practice niche, to seek to prove oneself as capable and adept, and to cement steps towards future growth. And maybe more importantly, to make sure you don't make any missteps to prevent future growth. Equally important, this is a time of great personal growth, financial changes from a trainee to an attending salary, and financial issues may change in nature. There may be this notion of wanting to catch up, looking at other people your age in non-medical professions and seeing their financial situation as compared to your own. There's also the sense of wanting or seeking to find a personal and professional balance, maybe one that isn't available during training. So let me first discuss a little bit of the basics of financial issues. So an overarching financial plan is useful. This can be created independently with the help of one of many different types of professionals. Short-term goals may include paying off debt, especially those with the highest interest rate, minimizing costly expenditures such as new home, new vehicles, and extravagant vacations. Long-term objectives are important, though retirement may seem early to discuss or consider. Planning for it at an early stage is obviously important, and guarding one's earning potential against future issues may be important, and so you may consider different types of insurance as well. Roughly speaking, to create this financial plan, I think it's important to have an evaluation of assets and liabilities as well as income and expenditures. This allows for an assessment of where you are. Are you ready to save, or do you need to start minimizing your expenditures in order to get to where you're saving? Popular resources are listed on the slide. Baum's book is written by a physician, talking about the 3 stages of a physician's career and the financial implications there. And then certainly the White Coat Investor series has been very popular, both the book as well as the other resources that are available. Financial planners are controversial, but can be useful, and one really needs to understand the different types of financial planners that are available. Most of us are approached at some point in training by a financial advisor. This is almost always an insurance agent who offers a free dinner, and then you sign up for disability insurance, and then they offer financial services. One can consider a fiduciary financial planner who may be less incentivized by commissions on products that are sold. And then consideration of having an attorney, either personal or for specific hazard assessments and needs, may be important to protect oneself. Some good general rules is to have at least 3 months of expenditures in terms of cash, maybe more so if your income is not as predictable. And to plan for future issues, because obviously the worst time to cash in an investment is when you're being forced to do so. From a personal perspective, there can be many causes of dissonance for an early career physician, and I listed chief amongst this imposter syndrome. And this manifests itself as a true psychological burden. You know, should I truly be here? Am I good enough to be here? Do I belong amongst my peers? Can I do this independently? There's much literature and discussion about disclosure. When do you tell your patients that this is your first time doing something or your first time doing something big? How do you tell you, even if you're planning ahead for a big case and you have your partner there, do you disclose that you have your partner there? Do you explain why you may have your partner there during that case? Should you make these disclosures? Are they ethically advisable? Are they ethically necessary? Managing complications can really cause one to question their self-worth and exacerbate the imposter syndrome we discussed earlier. There's also the notion of second victim syndrome with these issues. Often a complication will be the first exposure to risk management and understanding what risk management's role is in protecting a physician versus an institution, and that perhaps that the focus is more on the latter rather than the former. We've discussed burnout at this conference and many others, and the idea of mitigating early burnout or the desire to get involved and be present and be doing cases. And I would say that certainly a surprise for me is the idea of dealing with change. You know, in training, you're protected against change. Your day-to-day doesn't move based on who's there. But if you're young and you're starting a program and a key faculty member leaves, you know, how do you deal with that? How do you pivot in your career? And really to understand that change, at least in the surrounding faculty and surrounding institution, is part of every day. That's part of every job. Pediatric surgery continues to move towards further subspecialization, and sometimes this can provide a push, whether attractive or not, for pediatric surgeons. Thank you for the opportunity to discuss the early career issues.
Well, good morning, and thanks for all coming here and being here on the last day of APSA. So I am the chair of the Canadian Association of Pediatric Surgeons, Committee on Medical Legal Issues and Ethics. And I think this is actually a pretty important topic, and it's actually something that many of us were never taught during our training. It's stuff that we've seen along the way during our careers. We've seen surgeons as they get older, do things that, you know, may be good and some that may not be good. Some retire and some hang on. And as someone who's entering his last third of his career, I've reflected back on the middle part of my career and put some stuff in here which I think is important to think about. A lot of this is personal and may not fit with your current career, but it's something that I think is important as one looks forward towards your late part of your career. So I have a few questions. I'll throw them out to you as you think about things. During the middle part of your career, you should aim to pay off your mortgage, save for your children's college, evaluate your spending patterns, update your estate plans, or all the above. Polling question 2, how many surgeons report experience pain in the back, neck, and hands? Less than 10, 25, 50, 75, or greater than 90%. And the last polling question is, for those individuals at the middle part of their career, what are the rates of emotional exhaustion? Less than 10, 25, 50, 75, or greater than 90%. So we'll answer these subsequently on the following slides. So as I imagine one's career, this is kind of how I think about it. That first part is your climbing and ascending is often associated with your assistant and moving on to your associate professor if you're in academia. Where we're talking about is when you essentially have hit that mark. You are in your middle part of your career. Presumably things are going well. I'm going to be positive here. Everything's going well in your career. Everything's gone smoothly. You've advanced your career and you've made some decisions about what you're going to do. Whether you're going to be where you're working, how you're working, what you're choosing to specialize if you're choosing to do that. And presumably during the middle part of your career, clinically, you are probably, as most people say, at the peak of your skills. You are as up to date as possible. You are up to date with technology. You're bringing things on. People are referring patients to you. From a clinical standpoint, this is a sweet spot in your career. And that, like the person on the left and the right, you are usually celebrating that you've actually hit it. You've really made your mark. But what I want you to do is actually think about being on that person to the left part of the mountain, looking ahead. How are you going to take where you are in the middle of your career and actually make that so that as you are in your late career, and even after your surgical career is over, making that a really sweet time of life as well. So we're going to focus on how to look ahead and how to really prepare yourself so that during your late and after the time you hang up your surgical scrub cap, you are as happy as possible and thriving. So financially, Badder's also talked about this as well, and I'll just highlight a few points during your middle career. A lot of people think that this is actually a really important financial period where you actually have to correct all your financial issues and really address things from a financial standpoint so that when you are retired, you are financially sound. Paying off your mortgages is really important. Making sure you save money for your college tuitions for your children, if that's part of your plan financially. And then reevaluating career from a financial standpoint. What that basically means is, what is your salary? Is there ways of boosting that? Is there additional funds that you can do in order to improve that? Again, you're trying to lay in your nest egg so that later on you have as large a nest egg as possible. Some people actually choose at this point to actually change jobs from a financial standpoint. That may be something that's important to you. Looking at your spending patterns at this point, making sure that you're preserving your nest egg as much as possible, and planning estate planning, which a lot of people don't want to do. Make sure your wills are all set up, making sure everything financially is accounted for. So from a financial standpoint, the polling answer is E. You have to look after all these issues. A financial planner is actually very useful. My wife and I made sure that we had a good financial advisor and made sure that all from a financial standpoint, everything's looked after for our children. And for many of us, as we look forward, as we age, we're looking forward to our parents as well and making sure their financial affairs are all in order. So it's not only yourself, it's everyone in your family and making sure that everything is laid out as best as possible. And that's something that we're doing right now. And so from a health standpoint also, you want to make sure that you are physically as healthy as possible. And this allows one to determine when you want to retire. I've seen people who have had many injuries who have, as a result of that, their injuries dictate when they retire. If you can adjust things, you can be the decision maker and not let physical ailments dictate your time to retire. 90% of surgeons experience pain in the back, neck, and hands. So that's basically everyone. And almost 28% report an injury or chronic condition. But only 29% seek care, which basically means a lot of us are hurting and we're just letting it go. And so it's important for us to focus on that. And again, there's many different lectures and discussions about ergonomics. This is not a lecture on that. It just identifies, in terms of retirement, you need to address these. It's not easy. And things that we can solve are things that are possible for us now, which are, so how many times have you looked in the OR and seen people standing like that on the left? And it just pains me to look at that. Ideally, and again, I'm not going to go through the ergonomics, you want to be on the right side. And things that can help, there are loops that are being made now which allow you to stand vertically. I mean, I bet you all started with loops that everyone bought and your head was turned like, or bent over like the person on the left side. There are loops now that allow you to stand up straight. I'm not going to advocate for any company particularly, but there's many out there. If you don't have one, might as well have a look at some new pair of loops if you haven't changed them recently. Many of them will actually have headlights built in to the loops themselves and takes away the heaviness of the large headlights that we're all used to. Exercise. How many of us actually exercise routinely? That's something that during my last 10 years is something I focused on. Having good health is something that will promote long-term health. So carve out time in order to make sure that, again, your physical ailments don't dictate your ultimate decisions for when you retire. And now I'm going to bring up a term which I learned while putting this together. Middlescence is a term that is dictates 35 to 54 years of age. I've hit 55, so I've gone through this. And it makes up more than half of the workforce. So I'm going to make the assumption that half the people at APSA are in this age range. And it can actually be a time of frustration, confusion, and challenges for a lot of people. And interestingly, if you look at workforce statistics, 1 in 5 are seeking opportunities in new organizations. 1 in 5 are looking for major career changes. Why is that? If you've hit the perfect sweet spot in your career, it's because during this period of time, there's actually other things going on. Emotional exhaustion, burnout are at the highest rates during your middle part of your career. So why is there this dissonance? Well, there's this interesting graph, which is fascinating to me, which looks at your happiness ratio. And it's lowest during this middle part of your career. There's probably lots of explanations for why that. I am not a psychologist or social scientist, but I find it fascinating that during the time that you should be happiest in your career, why is there unhappiness? It is possible this other term, ikagai, which is the reason for being and having a direction of purpose in your life, may be something that I might explain this. This is a term that is Japanese and essentially goes back to the concept of why are you doing what you're doing and is it making you happy? And the way I think about this in the context of your career is imagining your best, next, and post-surgical career. During this period of time, are you setting yourself up so that your next or your post-surgical career is going to be something that you really want to be spending your time on? And so during this time, a lot of people, if you look at your colleagues, a lot of people recently have done other things. They've done additional degrees. Some have pursued MBAs. Some people have done a whole bunch of other training. And what I think is going on is people are essentially trying to determine what is making them happy and seeking that out during this part of their career. It kind of identifies where people have, for many, many years, been on one course in their life, getting to pediatric surgery, getting that first job, and after that first 5, 10 years of your career, you then start thinking about what do I really want to do in my career? And starting to take some ownership in how you want to spend the next 20, 30, 40 years of your life. And people are starting to take charge of their life. They're starting to actually change their careers during this period of time. Some people leave clinical practice. Some people do many other different things. I've seen it happen in all different networks. And people build their networks in order to actually do this. They leverage stuff that they've done up until then. Perhaps sometimes even before getting into pediatric surgery. Some develop new skills. And so ultimately, what I think your middle career really should focus on is focusing on yourself, what you believe is important for yourself, and spending time on things that you really think are important. And so as I reflect on this for myself, during that first phase, I've gone through all the academic pursuits and attained my professorship during my middle part of my career. We focused myself on our finances. I've focused on my health. I've had both carpal tunnels fixed during the last few years from all the double gloving that I've been doing over the last 20 years. And I focused on my career and what I want to do. I personally pursued a Master of Healthcare Administration degree. It was something that I really was interested in doing. And I pursued different roles that will hopefully I will thrive in, that will be set up for my late part of my career and even beyond. I'm thinking of possibly doing things like consulting after my clinical surgery is over. And so I'm setting it up so that I can be able to do that later on. So this is just my own personal career. I hope that your middle part of your career is something that you can see as thriving for yourself. And I'll pass this on to Dr. Bagwell.
Thank you, Ken and Badr, and I think you can see this progression that we've talked about is such an interesting way to look now at, which is sort of the conclusion of this, the so-called graying of surgery, or in some cases, the balding of surgery, that begins with a realization that a large number of people fall in this category. It's been estimated that from 1/3 to 1/2 of all the surgeons, not just pediatric in the U.S., are greater than 55 years of age. And most of them are still working at age 60. Now, one of the leaders in this discussion has been a fellow named Laser Greenfield, who was at one time the chair of the Department of Surgery at MCV, where I come from, subsequently at the University of Michigan. And he's done a number of reviews. One was some time ago, back in 1994, but the data then showed that 17% of all surgeons were still working at age 70, oftentimes at a normal schedule, although it was sort of up to them to decide what that normal schedule was. And interestingly, just almost 50% had not made any retirement plans whatsoever. The question then is, how many older surgeons are there over time? And that data indicates that that number may actually be increasing. Now, I have to tell you, that data that supports that may be somewhat suspect, because the last few years with COVID regulations and others are changing things. But disregarding that, the last we have good data for, in the American College of Surgeons, for example, it's estimated that there are 6,000 senior fellows, that's greater than 70, of which I am one, that pay no duties but are still operating. And if you correlate that about 25 to 30% of all surgeons are not only 25 or 30% of surgeons are members of the American College, it may be that there are 20,000 surgeons in North America that are still operating greater than 70 years of age. And if we look at our organization, APSA, with credit to Tom Tracy and administrators, there are just under 1,000 members of APSA. The senior membership is 329, identified by those that are over 70 and retired. I have looked at the entire list of 329, and of those, there are 20, I'm one of them, identified as still working either full or part-time. Now, the data is mutually exclusive, so it's a little hard to pin down the numbers. And frankly, that's the point of all this. It's a little hard to say, but the question still comes up, when should a surgeon stop operating? There's a famous quote by Michael DeBakey, that famed cardiac surgeon. We use his pickups all the time, don't we? And he said, at age 91, practicing cardiac surgery, I wouldn't mind being operated on by a 91-year-old surgeon. Interesting point of view. Clearly, when one recognizes that there is a decline in both cognitive and physical skills with age. After all, only wine and cheese improve over time. And the issue physically of strength itself, you know, your peak strength is at age 28. By the time of age 65, it's decreased by at least 25%, as does your eyesight. By age 55, you require 100% more illumination at the operative field. And I thought it was just the lights that weren't good in here today. But let's face it, surgery is clearly different from non-surgical specialties. In dexterity, which peaks at about age 45 to 50, and in the cognition that we know is intrinsic to surgery, what's called reaction time, the ability to rapidly think clearly in complex and dynamic, stressful situations. That's in the operating theater, isn't it? In addition to, as we all know, those increasing chances of chronic medical conditions that Ken has talked to us about. And studies of older doctors in general, not just surgeons now, but older doctors, show that the increase of cardiovascular complaints we all attended to clearly increases with age, as do the cognitive areas of practicing medicine in general. Again, among all older doctors, 54% were found to have some cognitive impairment that reached the level of frank dementia in 12%, depression in 22%, and a wide variety of other concerns, including a rather substantial rate of substance abuse, both alcohol and drug-related. As Ken has pointed out to us, those aches and pains of attenuated years of surgery do play a toll. And the laparoscopic surgeons have told us that 87% of them, as Ken's pointed out, do have chronic aches and pains they live with. And many of you can sympathize with those days when we used to do pull-through procedures for Hirschsprung's disease, and tiny babies open and were frozen for hours with loops into a tiny baby's pelvis, and afterwards would go looking for a massage therapist. It's the days that we've passed. Well, that being said, it certainly is appropriate that there should be some assessment for actual competence for surgery, and those exist, right? For example, there are state boards that assess one's competence, but if you look at those, they're really based on what? They're based on disciplinary complaints. The review process is a gradual one, but studies have shown that the rate of disciplinary complaints increases significantly by every decade following licensure. Other means of enforcing competence include the CME credits we get, minimum certificate for certification that we go through periodically, and the recertification process. But in actuality, looking at those, the data for that, very few people fail that. At the end of your career, people just drop out and don't practice anymore. So there are some studies that have looked with actual objective data, one of them again by Laser Greenfield, 2008, a study called CCRASS, which stands for Cognitive Changes and Retirement among Senior Surgeons. What he did is took a collection of senior surgeons at yearly American College of Surgeons meetings, and this group volunteered for a fairly intensive set of tests. And those tests would evaluate their attention, reaction time, visual learning, and memory, and then paired them with surveys regarding their own retirement plans. And what they found was fascinating. There was some age-related decline in all of those physical testing areas, but no senior surgeon fared worse on all three of those categories than the younger surgeons. And interestingly, there was no correlation between those cognitive scores and retirement plans or decision about retirement. Surgeons can do it on their own, irrespective of how they scored. Another test called MicroCog was designed in 2001 by Trunke and Botany to test impaired competence. This was in later career physicians and included, but wasn't exclusive, surgeons. And it tested, again, a whole range of requirements of cognition. And his results showed that the scores did decrease with age, but there was no correlation of one's low score with either surgical incompetence or of bad outcomes. One test does show some change: the objective structured assessment of technical skills uses both bench and live animal simulation to evaluate technical skills, and the results are capable of distinguishing between surgeons of differing skill levels. And it does show a relationship between that skill level and some postoperative outcomes. But none of these translate into measures of actual competence. In fact, the best study to answer this question is actually a literature review from just a few years ago by Fraser and Tanzer, who looked using a variety of search engines at all of the English language literature assessing topics of surgical competence and testing. And they found, and I quote, "We could not find any universal, well-established, and accepted policies of testing for competency of aging surgeons." They say none test intraoperative cognitive skills, which is the most important test of surgical competence, and conclude age alone is a poor predictor of operative risk. Now, that said, there are some reviews of operative mortality for certain specific procedures. Those are coronary artery bypass grafts, pancreatectomy, and carotid endarterectomy that show an increased mortality rate for surgeons greater than 60 years of age compared to younger, but this was only applicable to those with low case volumes and showed very small differences in outcome. What can we conclude from all this? It's perhaps best stated by Albert Einstein, who said, "Not all that can be counted counts, and not all that counts can be counted." So, we know that the Age Discrimination and Employment Act, ADEA of 1967, prohibits discrimination based on age alone. But there are mandatory retirement age guidelines, as you see illustrated on the slide, for airline pilots at age 65 with no exceptions. For firefighters, 57. Air traffic controllers, 56. U.S. state judges, you see in the 70s, and surgeons in the UK are not allowed to operate in the public health system past age 65 or in private practice on their own past age 70. Some hospitals in the U.S. actually have their own regulations. They vary depending on age when surgeons have to undergo various tests of cognition or physical abilities. And what those ages and what those tests are vary a great deal. So, why would one want to continue operating at advanced years? Well, we all know the pros of surgery. It's intellectually stimulating. Working with their residents and students is fascinating. They have skills we just don't have. My computer skills are worse than non-existent, and the residents are constant guides to me in that process, and we learn from each other. I find each day absolutely delightful. And let's face it, we have wonderfully rewarding results from our young patients who bring us cards and gifts and hugs. That self-esteem and, yes, social prestige to some degree is worth it. Some would even say surgeons keep working because of an innate fear of death, with the statement, "Surgery is for patients, not surgeons." And yes, there are financial advantages, as well as a resistance to change. I dread the idea of cleaning out my office for 30 years. And we do get used to our daily routines, don't we? Yet, as some have stated, there are demons in the night, what are described as that haunting fear of adverse reactions due to your inability to do or think. A story is told of one senior surgeon who completed a difficult operation, but then had to find an associate to escort him back to his office. So, how might one then transition into retirement in some form as a pediatric surgeon? If competence is not strictly age-related, it's a complex question, isn't it? And it's clearly multifactorial, involving one's own health, one's family, and personal issues that may be unpredictable or change. And that may be an individual decision whether to modify one's schedule with reduced duties, quit taking call, or simply, as some of my colleagues have done, decide to just walk away. The key thing is your surgical career will be marked by changes unexpected and in unusual ways. Mine was, and I found myself some years ago attending seminary, which I would have never predicted. But it's a process, and it's dependent on, in many times, a group ethic that may be institutional, family-based, community-based, or APSA-related, as we've seen here. And it may be based on your interests. No, as Ken pointed out earlier, all of us have students and residents that come to us all the time, asking our advice. What should I do? I'm interested in this field or that field. How do I decide? And after talking with them for some time, I'm sure you do the same as I do. You tell them, what are you really interested in? What do you really want to do? What excites you? And no matter what the cost is, that's what you should do. I think that's true for us too, to use those interests you have and let them direct you rather than you trying to direct your life. But I would encourage you to do that in a gradual way, and don't burn bridges. After all, retirement doesn't necessarily mean disappearance. But look at it as an opportunity with reassurance that in the end, all will be well. All will be well as you decide it. Thank you. I'm sure there must be questions from the group for any of us. We'd love to hear your comments.
Thank you for an outstanding panel. One thing that's come to mind is as people transition in the late phase of the career, I think it's important that where we work redefines the metrics for productivity. It's no longer RVU based, and I think this also impacts the early as well as the mid-career surgeon in terms of the contributions of teaching and utilizing the resource that's provided by the mid-career and older surgeon to the teaching of residents and medical students, and using that as a metric for productivity. In addition to research and publications and roles on committees and going to meetings. Thanks.
Let me just respond to that if I could, and I'll pass to my colleagues as well. Mindy, you're exactly right, and I have been a strong proponent in my institution for evaluating surgeons, especially members of our division, by other metrics than RVUs. I decry the corporatization of medicine in general and surgery in particular that has turned us into factory workers dependent on a work output, namely RVUs, to determine our value. Heaven forbid if any of us go to a surgeon's clinic if his operative schedule the next week is light. That should not be the determining factor for the way that we practice, certainly not with children, but it does in particular ways. We should be valued for those things that we do that don't show up on our RVUs, in mentoring, in teaching, in guiding, in instructing. And I would call on all of you to, in some way, enact that within your institution so that you're not just viewed as a technician that does so many RVU units and are reimbursed based on that. Other comments from the group?
I totally agree. And I think that during the last probably about 10 to 15 years, where healthcare has essentially become a business, that model of you're there to make RVU or look after a certain number of patients and so forth becomes the metric by which one's judged. And that certainly has saddened me, because that's not why I went to pediatric surgery. And part of why I chose to kind of go towards the administrative side is so that one can try to come up with ways to build in to why it's important not only to operate, but also to teach, as well as do research, and how to blend all of that in together and make it so that the hospital, the institution sees that as important. But I agree. I think that's something that we continue to struggle with, because ultimately the bottom line of the hospital, even for nonprofits, ultimately is how many cases you're doing, how many RVUs you're producing. But ultimately your personal satisfaction has to be more, or probably less, on how many kids you've operated on, but how many lives you saved, and how many futures that you can actually create in terms of trainees that want to go into pediatric surgery or surgical field. So I think it's a work in progress. I think that we're going to have to all help each other make sure that these things are valued.
Yes.
Jeff Seitz from New York. Because I too am in the septuagenarian group, I had to write these things down so I wouldn't forget them. I think this is a wonderful conference, and I would encourage the program committee to continue to repeat this every year, because there are going to be new members joining each of these three categories, and refreshing the information I think would be valuable. To Badr's comment, I think it's important to realize, or to his subject, I think it's important to realize early on that standing on one leg is a very unstable situation, unless you're a flamingo. And so we have lots of legs to stand on. We have our trainees, our friends, our colleagues. And so know that you can seek help and support from other people the way that you would welcome supporting them if they came to you with issues. Sort of crossing both of your talks, I'd also recommend the For Dummies books as far as self-education about finance, personal finance. They're very readable. Some friends of mine went to Cedars-Sinai and spent their whole careers there. And about 5 years ago, they put on a seminar on the aging surgeon. And each of them was at or near 70 at the time. And one of them, who actually is the reason I went into surgery, the eldest of the group, got up and talked very humorously about when people develop shakes and that sort of thing, and people talking about people develop a shake. He's a vascular surgeon, and he said, if you want to see somebody shake, watch a fellow the first day in practice doing a ruptured aortic aneurysm. He said, that's a shake. But he said wisely, I think, that when you realize that you can no longer put the effort into caring for a patient the way that you know you should, then it's time to reconsider whether or not you should change what you're doing. My personal journey has been to be able, and I've been very fortunate to be able to do so, is to just pare away some of the things that are more difficult and things that I no longer want to do, but also don't want to do because I have younger people who are just out of their training and I don't need to do another TE fistula when it's a mitzvah to make room for somebody else to do it. And that's another mantra, is thinking about, as we move on in our careers, making room for the people that we train. Thank you.
Thank you for your comments. I think in line with what you just said, yes, the idea of collegial support is one that we should carry through with us at all stages of our training. In our particular practice in Richmond, Virginia, we practice at the medical center and in the community hospitals as well, where we don't have the ability to take residents. So we have a practice there. We're doing a big case, and not many of them are, but sometimes they are. We'll get one of our associates to come and join us. And I have found it to be absolutely delightful to have that support. If you haven't done a choledochal cyst in several years, to have a friend come and scrub with you makes it a delightful experience that takes the pressure off. You've got an extra person to go through the steps and to judge and guide and direct you. And I think carrying that into our institutions, even the medical center, is helpful. I mean, you're right, those big operations that we were in the old days told, you know, you never had help, that was a sign of weakness to call someone in. That's just baloney. Having a senior surgeon to come in, even if they come in for advice during the operation, is so reassuring and helpful, especially at those cases where you're looking at resection of a kid, for example, with, name it, a volvulus, and you're looking at length of bowel. When is it ischemic? When should you resect? How should you do that? And the ability to have an associate to be there and guide you through difficult moral questions is enormously reassuring. So we're talking about collegial support. Don't you folks at various stages think that's helpful, not just in late career?
Yeah, I was going to say that when I began my career, I thought, as you have stated, you should never call anyone because that's a sign of weakness. But as I've gone through things, it is certainly not a sign of weakness. And having other people there and helping you is something that is more of a recent phenomenon, which is awesome. And I think a lot of our younger folks now in their first part of their career and entering the middle are really more attuned to the concept of working as a team. And I think it's a great thing to do. I think that's a phenomenon that I definitely would encourage. Having more hands on deck is something that only benefits a patient, and I think it's something that, as I said, I think it's our younger folks in our field that are really accepting that, and I think it's a great thing.
Tom Lee from Chicago. In terms of collegial support, I can't emphasize anything more than that. Personally, I came from a devastating health crisis, and you talked about your carpal tunnel, and Dr. Gao mentioned these are potentially devastating career-ending in terms of as an operating surgeon. And I think having collegial support as you come back to work, monitoring your work, proctoring your work, has really been a very helpful tool personally for me to gain confidence back in the OR. And I think this is something we should encourage everybody to obtain as they return, as a middle-aged or late surgeon comes back to work. And I think also getting a Porsche when you're a middle-aged surgeon's an excellent fix for that problem too.
It's a red Porsche. Is it red?
Yeah, I apologize for getting up again. I should put on Groucho glasses so I look like somebody different. But we live in our heads, and we we spend most of our lives talking to ourselves. And I think how you frame what you do can make an enormous difference. So asking for help by itself is not 100% of what the situation is. You're also inviting a colleague to come in and share something with you. And that can enhance their experience too. It makes them feel wanted. And so there's a gift quality to asking somebody to come in.
Other questions, comments from the group? If not, I'll share one final, somewhat humorous note that you may recall. And this is entirely unverified, but I ran across this in my preparation for this presentation, and it comes from a Maltese surgeon whose name was Felice, and he calls it Noddy's statistic. And it goes like this: if the combined age of the patient, surgeon, and anesthesiologist exceeds 210, the mortality is 100%. Well, gentlemen, anything further to add?
No.
No. Thank you so much for attending. It's been great to have you. And God bless.